Hello, my name is Eric Norquist. I'm a faculty member at Texas Tech University Health Sciences Center in El Paso, Texas. And I'm happy to present today on how to safely perform awake intubations. This is a typical photo that one would expect to see in a lecture about awake intubations. The patient has several features that would predict difficulty with laryngoscopy, most notably swelling in the submental space and a large elevated tongue, as this patient was suffering from Ludwig's angina. The patient in the photo, she was my patient, and she has greatly influenced my career more than she would ever know. It was still quite early in my first year as an attending, and I was working a slow overnight shift when this patient was rushed back to our resuscitation bay with tongue and neck swelling. She was hanging in there, but it was clear that she needed to be intubated promptly. As I mentally put together my plan, I thought about the options for airway management. An awake attempt using a flexible endoscope I judged to be the best plan. I reflected on my training. I felt competent to perform the procedure. However, I lacked confidence. But this was not a crash airway. We had time, so I elected to call anesthesia. A large anesthesia team came down, complete with several residents and an attending. They formulated an alternate plan, instead settling on a sedation-only attempt using a videoscope and a McGill's forceps to facilitate a nasotracheal intubation. Their intubation attempt was not without complication. Despite using only sedation, the patient stopped breathing and desaturated rather quickly, and the intubator struggled to pass the ET tube. The patient began to brady down just as the tube passed the cords. Thankfully, the patient went on to have an uneventful hospital course and made a full recovery, but this was a near miss to say the least. I felt as if I had failed my patient. I'm an emergency physician. Airway management is the defining skill of emergency medicine. This case truly motivated me to continue to work on my airway management skills in general, and specifically to shore up my awake approach so I feel not only competent, but also confident when these cases arise. So here I am speaking to you all today in the first ever ASAP virtual conference. This virtual conference highlights the unique time in which we are practicing medicine. One can have teachers and mentors from all over the world, people that they've never met. Yet these teachers generously dedicate their time to developing educational content and distributing it to learners across the globe. There are many well-known voices in the EM foam movement. The one that I've learned the most from regarding airway management is George Kovach. Many of you are probably already familiar with his work, but if you are just getting more interested in airway mastery, his is a name you should know. I highly recommend his website, aimairway.ca, and he's a good one to follow on Twitter. Most of what I'm going to talk about today, I've learned from following his work over the years. So my goal today is to not only outline the approach I have adopted, but to also motivate you to become confident in the awake approach and leave you with a strategy on how to obtain the necessary skills and incorporate them into your practice. Prior to jumping into the heart of the lecture, I want to briefly address 3 mental barriers that I believe hinder emergency physicians from learning and integrating the awake approach. Occasionally outside of the emergency department, and too often inside the emergency department, the flexible intubating scope is considered to be a tool of anesthesia. I have heard emergency physicians state, "I'm good at DL and I'm good at VL, so I'm going to stick with what I do well." This barrier prevents emergency physicians from even picking up the flexible endoscope to begin training. Prior to this 2018 study from Hayden et al. That came out of the NEAR database, we did not have much data as to how often the flexible endoscope is used in the ED. Out of the nearly 18,000 intubations in the dataset, a flexible endoscope was used in 1.1% of the cases. First best success was 51%, and overall success rate was 74%. This data shows that the flexible scope is part of the airway armamentarium of the emergency physician, and it belongs in the ED. Another barrier is a perceived lack of available opportunities to perform an awake approach. Classically, the awake approach is used in patients with difficult airway anatomy. Detractors point out that the number of patients who present to an ED with truly notable abnormal airway anatomy is quite low. Thus, their argument contends that the availability to develop and maintain skills for even the enthusiast is quite limited. However, in recent years, there has been an increased emphasis on optimizing the management of the physiologically difficult airway. This important article, published in 2015 from Moser et al., discusses the physiologically difficult airway. The awake approach does not solve all of the potential problems in managing these patients. However, it may mitigate some of the airway concerns when managing patients with critical hypoxemia, hypotension, and metabolic acidosis. We care for the physiologically difficult airway on a daily basis. Thus, opportunities to use an awake approach are abundant. The final barrier that I would like to discuss is that frustration and lack of success with initial awake attempts due to inadequate training can turn physicians away from mastering the procedure. One of the biggest reasons folks will struggle with the procedure is due to poor patient preparation due to insufficient lidocaine usage. The key to this procedure is to adequately topicalize your patients so they will tolerate instrumentation of the airway. Most emergency physicians do not have an accurate understanding of how much lidocaine can be safely used in order to obtain a dense block. The crux of the problem is there is no clear number as to the upper dosing limit of topical lidocaine, so most folks fall back to the typical 4 to 5 milligrams per kilogram of lidocaine that is published for intradermal use. However, when considering toxicity, it is the serum level that matters, not the amount of drug exposure. In contrast to intradermal lidocaine, we do not have reliable data as to how much of lidocaine applied topically is actually absorbed. Absorption depends on several factors. It depends on how the lidocaine is delivered, whether it's nebulized, atomized, or just dumped on the tissue. It also depends on the form of the drug, whether it's solution or ointment or gel, and also on how vascular the tissue is on which it is applied. It is known that the elderly or patients with cardiac or hepatic dysfunction are at an increased risk for toxicity. So what is the safe upper limit of topical lidocaine? Hung's Difficult and Failed Airway Management Text is a fantastic resource, and I highly recommend it to anyone with an interest in advanced airway management. Ian Morris, a true expert on this topic, wrote the chapter on awake intubations. In his chapter, he gives an incredibly detailed review of the pertinent literature on topical lidocaine dosing. After reviewing the best data available, though there may not be a clearly defined upper limit of lidocaine, one will conclude that it certainly is higher than 5 milligrams per kilogram. In 2001, the British Thoracic Society recommended an upper limit of 8.2 milligrams per kilogram for topical use during bronchoscopy. In the latest version of those guidelines in 2013, they refrained from making a clear recommendation. However, after reviewing that document, the previous recommendation remains reasonable. The 2013 version made the recommendation more general, stating that the lowest amount that is required for patient tolerance should be used, adding that serious side effects are unlikely to occur if one stays under 15 milligrams per kilogram, but that less serious side effects are likely to occur in patients in levels over 9.5 milligrams per kilogram. Despite a lack of clear guidance, 8 milligrams per kilogram remains a reasonable, safe number. However, it really is a risk-benefit calculation for each patient. In patients at increased risk for toxicity, I would try to stay more on the lower end. But if I'm caring for a patient with severe angioedema and reach 8 milligrams per kilogram, but the patient still needs a bit more lidocaine to tolerate instrumentation of the airway, I would feel comfortable giving a bit more. An important caveat is that one should do the math prior to the procedure and keep track and be aware of how much lidocaine is used so you do not go significantly higher than 8 milligrams per kilogram to avoid causing serious side effects. Now that we've discussed 3 of the barriers to learning and having success with the awake approach, let us move on to the particulars of the procedure. As I've already mentioned, obtaining a dense block of the oral pharynx and upper airway is the key to success. There are many different recipes and techniques that people have described. With the limited time that I have, I will discuss the method that has worked well for me. First, let us discuss some medications that you may consider using. Glycopyrrolate as a drying agent. The idea is that dry mucous membranes absorb the topical lidocaine better. However, the use of glycopyrrolate is optional as the technique works just fine without it. Time is what limits its utility. IV glycopyrrolate requires 15 minutes to work. I have used it in only a minority of the awake intubations that I have done, and honestly, I have not noticed any difference in the quality of the topicalization. Oxymetazoline for vasoconstriction of the nose. If I'm planning on using the nasal route, then I like to give a couple sprays to mitigate bleeding. However, this too is optional. Lidocaine is the only medication that you need. However, it is essential that you have the necessary formulations. 4% lidocaine solution is a must. Without 4%, you will find it difficult to obtain adequate topicalization and you will struggle with the remainder of the procedure. The other form that you need is 4% lidocaine cream or paste or ointment. 5% ointment likely would be ideal. However, I have never worked in a hospital that had 5% lidocaine ointment due to availability and cost. You may want to check with your hospital pharmacy to see if you carry 5% ointment. So to start, you will use a tongue depressor and the 4% lidocaine cream to anesthetize the posterior tongue. Place a dollop about the size of your fingernail on the end of the tongue depressor and plop it way back on the posterior third of the tongue. This step is very important, as in most individuals, the gag reflex is incredibly acute, thus it is paramount to anesthetize this area well. You then will slowly move the tongue depressor back and forth, let the lidocaine melt and drip down onto the epiglottis. I generally repeat this step performing 2 applications. I estimate you will use about 1 gram of cream, which is approximately 40 milligrams of lidocaine. Some of the 4% cream can also be applied to the nares if the nasal route will be used. Next, you will want to atomize 4% lidocaine. Years ago, when I first started performing awake intubations, I nebulized the lidocaine. However, it is a challenge to get an adequate block with nebulized lidocaine. The patient breathes in a lot of the product into the lower respiratory tract, and a lot of the solution is lost into the environment, so the medication does not go where you need it. Here's a recent publication that found that 4% lidocaine was much more effective than nebulized. The Easy Spray Atomizer is the device I like to use to deliver atomized lidocaine. The plunger gives you nice control over when your medication is delivered, and the bendable tip gives you control over where your medication is delivered. I generally use about 10 mL of 4% lidocaine. It can be sprayed directly into the mouth or through the nose. The benefit of delivering it through the nose is the air column pulls the medication down onto the larynx and into the proximal trachea. Instruct the patient to inhale 4 to 5 times through the nose. And the rest is sprayed onto the structures of the posterior pharynx and directed onto the larynx. 10 mL of 4% lidocaine is 400 milligrams of lidocaine. So at this point, you are around 440 milligrams of total lidocaine. Therefore, in your average patient, you still have quite a bit of room for additional lidocaine if needed for patient tolerance and still stay below 8 milligrams per kilogram. Many like to spray additional lidocaine through the working channel of the scope during the procedure. Keep in mind that it may not be necessary if you adequately anesthetize the entire airway prior to inserting your scope. It takes about 1 minute for your additional lidocaine to work, and you may cause side effects such as cough or even laryngospasm with the deliverance of lidocaine through the scope. In my experience, when delivering lidocaine through the scope, people tend to give more volume than is necessary. Patients generally need only additional 1 to 2 mL of lidocaine. So in order to deliver that, fill the syringe with lidocaine along with 8 mL of air in order to push the liquid through the working channel of the scope and drip it onto the epiglottis and larynx. Now that the patient is adequately topicalized, it is time to insert the device and deliver the tube. In general, I prefer to use a flexible intubating endoscope, though a video scope can be used as well. The Ambu A-scope was the first disposable scope on the market. It has made it much more easier to have the appropriate equipment readily available in the ED. Prior to the disposable scope, expensive fiber optic scopes were often housed in the OR, which greatly limited their availability to the emergency physician. GlideScope and Karl Storz now also make disposable scopes that are compatible with their video systems, so there are additional options on the market. So either the nasal or the oral route should be selected. Both routes have certain advantages that you'll want to keep in mind. The advantage of the oral route is that you can place a larger standard endotracheal tube. The nasal passage will accept generally only a 6.0 to maybe a 6.5 tube. The advantage of the nasal route is that it is technically easier to maneuver the scope through the cords as the nasopharynx leads directly to the larynx. When going through the mouth, the turn is much sharper, making it more challenging. So before inserting your scope, you want to ensure that your patient is also positioned appropriately and that you are comfortable. If possible, have your patient sitting up to close to 90 degrees and in the ear to sternal notch position to optimize airway alignment. Ensure that the screen is arranged to maximize your comfort. Position yourself to keep the flexible endoscope midline and straight. It is preferred to have the right hand high to maneuver the lever and the left hand low to guide the scope. Keeping the scope straight will help you direct it. The basics to driving the scope are quite straightforward. To press the lever to direct the scope up, elevate the lever to direct the scope down, and with the lever engaged, twist the straight scope to either side in order to direct the scope to the right or to the left. The first step of the nasal approach is to blindly insert the endotracheal tube into the nasopharynx until it makes a caudal turn at the posterior nasal cavity, and then the tube is extended to just the edge of the soft palate. This corresponds to an endotracheal tube depth of around 14 centimeters. Next, insert the lubricated flexible endoscope through the ET tube. The tip of the scope should be directly above the larynx as it emerges from the end of the endotracheal tube. Smoothly move the tip of the scope toward the glottic opening. So here is a video that will demonstrate that portion of the procedure. So this procedure was performed by a resident who had never performed an awake intubation prior, so her training was quite limited, and you can see how nice of a job she truly does. So initially the tube was inserted a bit too deep as the tube was resting against the wall of the oral pharynx. So here she pulls the tube back to give her more room to maneuver. Through all these videos, I want you to keep in mind the keys to driving the scope, which are to make frequent minor changes in the trajectory of the tip while always keeping the target in the middle of the screen. So here you can see how the procedure appeared from this vantage point. You can see her approaching the glottic opening and then proceeding through the vocal cords down through the trachea to nearly the carina. And here's a video from that portion of the procedure. So again, making small adjustments to keep the target in the middle of the screen. You can see her pass through the glottic opening and again down into the deeper trachea. So at this point then, the tube just needs to be passed over your scope. So here's the video from that portion. You can see the video shake a little as the tube is being advanced over the scope, and then tube position is confirmed as the tube is withdrawn. So again, you can see that the resident, despite having just sort of the basics of training, she did a very nice intubation. So one safety consideration that I like to keep in mind is that small caliber endotracheal tubes, they're also shorter. So a 6.0 tube is shorter than an 8.0 tube. The standard 6.0 tube that we stock is 28 centimeters in length. And that should be long enough for the nasal approach in most people. However, if you have a particularly tall patient, it may not be. I heard of a recent case in which a tall patient was intubated using the nasotracheal route, and the ET tube was under some tension because the tube was just a bit too short for this tall patient. And then due to that tension, the ET tube adapter popped off and the ET tube itself receded into the nasopharynx. Talk about an airway nightmare. So I like to have some of these extra long tubes designed for nasotracheal intubations available in the ED for such cases. So here's a photo of the resident performing the procedure through the oral route. And as I already mentioned, it requires greater skill to drive the scope when going through the mouth because the turn is much sharper. An oral intubating airway, such as the Williams airway intubator, can help guide the scope and keep it midline. However, with increasing operator skill, it is not needed. And so if you don't have an oral airway, if you put traction on the tongue, it will give more room in the oral pharynx to make the turn toward the larynx. And here's the video from the oral approach of this procedure. So when intubating through the oral approach, you can see the idea is much the same. Stay midline, keep the scope straight, make minor adjustments to the tip of the scope to maintain the target in the screen as you advance. And another successful intubation. As I mentioned, you can also use a video scope. When using a video scope, it is vital that you obtain a dense block to the posterior tongue and epiglottis, as those are going to receive pressure. So you want to position the patient in a semi-recumbent position with the intubator toward the head of the bed just to the patient's left. As you enter the oral cavity with the VL blade, try to avoid touching any soft tissue until you have your blade tip in the vallecula. For this reason, the standard geometry Mac blade is preferred over the hyperangulated. Then you just insert and pass the tube while trying to avoid contacting any soft tissue. Using a bougie to assist is also a good option. So here's the video from this portion of the procedure, which is typical of that you would see if you're standard RSI, just with a bit more care to avoid touching the soft tissues. So lastly, I'd like to leave you with some ideas on how to gain competence and confidence in performing this skill. So the first step is working with your department and hospital leadership to obtain access to the necessary equipment and medication. And once you have that in place, all it is practice. I recommend simulation as a first step to obtain a basic skill set with driving the flexible endoscope. I borrowed this idea from Denver Health after I saw it on their Twitter feed. You can use PVC piping to make a maze to practice manipulating the scope. The maze provides much more robust practice than just a standard airway mannequin. So after a session to familiarize yourself with the scope, the next step is to use your skills on a real person. This is also how you will gain competence in performing topicalization. I think it's great if 2 or more physicians who are learning the procedure can meet up and practice on each other with mentorship from someone experienced in the procedure. The participants do not necessarily need to intubate each other, but doing the topicalization and driving the scope through the nasopharynx on a real person and having it done on them really builds their confidence, and it also helps them talk their patients through the procedure in the emergency department as they have experienced the procedure themselves. At this point then, I encourage learners to use their new skills as frequently as possible in the ED. Topicalize your patient and perform nasopharyngoscopy instead of ordering a CT for that patient with severe adenophagia or a hoarse voice, or just take a look in that patient that swears he has a fishbone stuck in his oral pharynx. There are multiple opportunities to use this skill in the ED to build your skills. After performing several nasopharyngoscopies, you will have the required skills to perform an awake intubation. To further gain competence, I recommend performing an awake intubation on a patient who is not predicted to be difficult. If for some reason you struggle with the awake approach, you still have all your other airway options available. However, I predict you will be surprised at how well the attempt will go. After completing a handful of awake intubations on patients with normal anatomy, you will be competent and, more importantly, confident when the patient with abnormal anatomy presents to your ED. Lastly, some homework. As I mentioned at the beginning, I have learned so much from George Kovach's work. He has many great airway videos on his website. Find his lecture on the awake intubation and his interview with Ian Morris on the MCRIT site. Also, it can be intimidating to learn a new skill, whether it be awake intubations or something else. In his TED Talk, author Josh Kaufman addresses the emotional barriers of learning. I found it to be quite inspiring. So in a couple months' time, when you are no longer feeling motivated to master the awake approach, I highly encourage you to review these resources. Now in closing, I took this photo over 10 years ago. As we spoke prior to the intubation attempt, my patient gladly gave me permission to take her picture. In a time when most would be overcome with fear, she expressed a true eagerness to let me use her story to help educate others. I would like to thank her and all of the other patients that I've had the privilege to care for. Thank you.